Yes, yes.
Good evening. Good evening to all. This is Vayomanasa. Namaste and good evening to Dr. Aarthi Kannan, resource person of this evening, Mrs. Jyoti, and her team from NIMHANS for providing online and offline support for conducting the webinar. Dr. Professor P.T. Sivakumar, Head of Geriatric Unit of NIMHANS, and Dr. Vijay Kumar Epishetar and his team of doctors who are responsible for this webinar. The enthusiastic and inquisitive viewers and participants of this webinar from across the country. I have great pleasure in welcoming you to yet another edition of this webinar, being offered by Vayomanasa Sanjeevani and all of Geriatric Unit of NIMHANS Banglaore. As I am seeing a number of new faces, I would like to provide a brief overview about Vayomanasa Sanjeevani. Most of us know National Institute of Mental Health and Neuroscience, NIMHANS, which is a world-renowned as a center for mental health, neurosciences, and allied fields. They have geriatric care as a specialized unit, and in that unit, they have started the webinar services to create awareness to people at large about the development in the field so that everyone can benefit by directly hearing from highly qualified and experts in the field of medicine. Now, I take pleasure in welcoming and introducing to you Dr. Aarthi Kannan, a distinguished, highly qualified and busy geriatrician and neuropsychologist in Bangalore. She specializes in the comprehensive care of older adults, focusing on their unique health needs by promoting wellness and through emphasizing on preventive health care. I understand that neuropsychology is the study of how the brain works and how it relates to behavior and cognition. It is a subspecialty of psychology. Dr. Aarthi Kannan can examine the ailments of body and mind, especially of a senior citizen, and evaluate cognitive functions and behaviors, diagnose and treat neurological, psychological, and behavioral disorders. She can treat a wide range of conditions from concussions to complex neurological disorder. Dr. Aarthi Kannan has secured her MBBS degree from the KJ Somaya Medical College, Mumbai in the year 2012. After obtaining her MD in Internal Medicine, she has qualified for fellowship in geriatrics from Stanford University, California, US. She is certified by American Board in Internal Medicine in the year 2018 and in Geriatrics Medicine in 2019. She is a professional member in American Geriatric Society. Her professional experience includes a 3-year stint at UConn Health Internal Medicine, Connecticut, US, as resident physician. She had been a clinical fellow for 1 year at Stanford University, Department of Geriatrics, where her focus was on outpatient and inpatient geriatric medicine. She is practicing in internal medicine and geriatrics for a number of years. She has a number of notable achievements to her credit. She has multiple peer-reviewed publications in top journals. She has presented papers in the American Geriatric Society International Conference for Geriatrics in the year 2019. Her area of treatments start from geriatric primary care, transition care from hospital to home, geriatric oncology, home-based care for older adults, management of diseases like dementia, etc. She can intervene in incontinence, sleep disorders, management of pain, appetite, depression, and anxiety. She does safe prescribing. She does caregiver education and counseling. The topic of this evening, that is managing caregiver expectations, is very relevant to most of us, as often we are either caregivers or care receivers. The task of caretaking of a dementia patient needs extreme patience and special training. However, the task of taking care of a person with a neuropsychic disorder is quite challenging. Therefore, we are today fortunate to hear from such an accomplished specialist on caretaking. I thank Dr. Aarthi Kannan for sparing her valuable time and using her knowledge to educate us on this important topic. Doctor, as far as we are concerned, we are a set of mostly seniors interested in maintaining good health for ourselves as well as for our near and dear and people in the society. With that objective, we listen to experts like you and implement your suggestions. We take your suggestions to various forums also. As a meeting hygiene, I request all the listeners to mute their mic and listen to the resource person carefully. In case of any doubt, they can send a message through chat for the speaker to respond at the end of presentation. If time permits, they can mute and raise their doubts at that time. Yes, Dr. Aarthi Kannan, now the floor is open to you. Please go ahead with your presentation.
Thank you, Jambunathan sir. Thank you so much for your very kind words. I will only say it is your own kindness and blessings that has got me here. So thank you for having me here, and thanks to everyone for patiently waiting until this session has begun. So just as Jambunathan sir has introduced me, I am a specialist who takes care of senior citizens. So I specialize in the care for people who are aged 60 years and above. And one of the common questions that comes up to me whenever I meet a senior citizen with, let's say, memory issues is, how do we deal with or how do we support this individual who has a certain issue with their memory and their daily functioning, whether it is dementia, whether it is any of the disorders that involve memory, cognition, and function? So that brings us to the topic today, which is managing caregiver expectations and caregiver support. So an important part or a task that we are to deal with in today's day and age when we speak about treating dementia is also enabling, supporting, and empowering the caregiver to be able to care for the individual who has dementia. Neuropsychological disorders form a part of the same spectrum of diseases where it affects the neurological aspect of the individual as well as the psychological aspect. So we've covered the caregiver expectations in both of these syndromes that occur in elderly people. So in today's presentation, we will be covering the following topics. We'll be defining who a caregiver is. We'll be talking about the broad types of cognitive dysfunction. Is it normal aging or is it dementia? Then we'll be speaking about what... I would request all of you to kindly mute yourself so we can go on without any interruptions. Please mute yourself. We'll be speaking about mild cognitive impairment versus major neurocognitive disorders, risk factors for cognitive dysfunction, what are the early warning signs, setting the right expectations with caregivers, unique clinical features of each type of dementia, using diagnostic tools to aid us in the diagnosis of dementia, common challenges for caregivers of older individuals with dementia and neuropsych disorders, educating the caregiver in terms of caregiver support or CGS, caregiver fatigue or CGF, and how do we help caregivers to come to terms with it, and finally preparing the caregiver for handling their loved one. Next slide. So a definition of a caregiver, a person who gives care to people who need help in taking care of themselves. So that's all a caregiver is. What it would entail would be anybody, right from someone who's, let's say, a caretaker, a hired caretaker at home, or a loved one, a family member. Let's say it's a healthcare provider, a doctor, a nurse, a person who's receiving the patient in the OPD or the inpatient department. Everybody along the spectrum of giving care to this individual is known as a caregiver. But the most important aspect when it comes to discussing caregiver expectations is the caregivers who maximally interact with the patient. Usually that would be loved ones, family members who are in daily touch with the individual who is affected with cognitive impairment, as well as hired caretakers who are usually hired for the purpose of giving support to this individual. Next slide. The broad classification of cognitive dysfunction that is of interest to us today would be mild cognitive impairment and major neurocognitive disorders or dementia. So dementia is also known as major neurocognitive disorder.
Godavari Saraswati Narmade Sindhu.
We have some very interesting additions here today as we speak about the
Yeah, Jyoti,
dementia.
just 1 minute, Doctor. See, Jyoti, kindly unmute everyone, Dr. Jyoti.
Yes, actually, I'm doing it.
Yeah, in fact,
Can you see the slides? I want to
can
that in a-
only the mute condition. That way, yeah, mute all. Okay, ma, please.
Is everybody able to see the slides that we're discussing?
Yeah, everything is fine, ma. Everything is fine.
Okay, okay. Now, are all types of memory impairment considered as mild cognitive impairment or dementia? The answer is no. The vast majority of memory impairment that we see with age is actually not pathological. It would be the minority that would be considered abnormal, such as dementia or mild cognitive impairment. However, we do have a decline that occurs with age in our cognition, in our memory, in all domains of functioning neurologically. So the common term that we use is age-associated memory impairment that is considered as physiological or natural as age progresses. Now, how do we differentiate this from, let's say, abnormal memory impairment? That is, how do we differentiate it from dementia? Patients experiencing difficulties with memory, but not noticeably disrupting their daily life, not affecting the ability to complete tasks as they usually would. No difficulty learning and remembering new things. No underlying medical condition that is contributing to these memory problems. So this is called as age-associated memory impairment. That means that there is no actual disruption in day-to-day activities or in their daily life. Older people, so a study actually showed that older people are more likely to experience thought confusion and fatigue than younger individuals when performing prolonged cognitive tasks. So prolonged tasks involving the brain, older people are more likely to experience thought confusion and fatigue, maybe due to reduced efficiency of executive control in the frontal lobes of the brain. So this is important to recognize because this is something that tends to happen just as a result of aging, is what this particular study showed by Washer et al. In 2014. So if you look at the diagram in front of you, there are two green lines on top that show the normal aging associated cognitive decline. But there is an abnormal graph that goes off the light blue line, and then there is a darker blue line followed by a red line, which shows the drop in cognition and memory that is associated with mild cognitive impairment and dementia. So there is a preclinical phase, the clinical or MCI, and then there's dementia. Preclinical phase is where, the patient knows something is up, something is wrong. I'm forgetting things more than usual. It's disrupting my day-to-day activities. But really, the doctor doesn't really know about it. Because they're not able to express what it is. They think they're just being forgetful. They say, I don't remember a lot of things, but it's okay. Things are going fine and I'm okay. MCI or mild cognitive impairment is where the memory changes start to concern the patient and sometimes even the family. It's enough to show that one of the cognitive domains is affected. If I were to do a memory testing or a screening on a person, I would get to know that they have mild cognitive impairment. But the activities of daily living, such as taking care of themselves, bathing, brushing their teeth, hygiene, clothing, like wearing clothes, doing their day-to-day activities is usually not impaired. They're basic day-to-day activities. Now, dementia is where the impairment is severe enough to interfere with these daily activities. And usually, what do I mean by daily activities? I'm not talking about financial planning or, maintaining a telephone book. I'm talking about basic things like taking care of ourselves, being able to feed ourselves, being able to bathe, being able to wear our clothes by ourselves without any assistance. So one or more of these domains starts getting affected with dementia. Next slide. So MCI versus major neurocognitive disorder, just to summarize what I've already spoken to you about, MCI is a reduced area or mild cognitive impairment, reduced area in at least one area or reduced functioning at least one area of cognitive function compared with age and education matched control. So if I were to take a control who is, considered average normal for that particular age and education level, this person would fall a little lower than them. There is no disruption in activities of daily living, which means that they can carry out their day-to-day activities quite well without any disruption. The patients are often aware that there's a memory impairment. Sometimes they even try to compensate for it. They try to make up information to fill those gaps in memory. And they know something is wrong, which is why they're trying to compensate, which can frequently lead to distress. They say, I keep forgetting things. This is not how I used to be. I used to be so sharp, but now I'm just, I keep misplacing things very often. In contrast, patients with dementia lose this awareness that they are, they have gaps in their memory. So that's quite frequently noticed that patients who progress to dementia, they lose that awareness that the memory is going. So dementia or major neurocognitive disorder is a decline in at least cognitive domains, along with disruption in activities of daily living. So the second part is really important. There has to be a disruption in the activities of daily living where there is an interference in the day-to-day activities that's causing them to have that functional cognitive impairment. Now, risk factors for cognitive dysfunction: stroke, family history of Alzheimer's dementia, vascular dementia, cerebrovascular or stroke risk factors such as diabetes, hypertension, long-term medications, for example, but not limited to benzodiazepines and non-benzodiazepine sedatives, age-related hearing impairment. So people who have issues with hearing, progressive hearing loss related to age. Visual impairment is a risk factor, but it is not true that all people with visual impairment will have a cognitive impairment. There are people who have even clinical blindness who have very sharp memory right up to the end of their life. So this is more of an association rather than a risk factor. Depression and anxiety are quite significantly associated with mild cognitive impairment and Alzheimer's dementia. It is not yet known whether depression and anxiety lead to MCI and Alzheimer's, or whether they start along with these two, or whether they start after the cognitive impairment begins. But there is a strong association between depression, anxiety, and cognitive impairment. Social isolation is a significant risk factor because social interactions involve complex, cognitive domain involvement. When we speak to other people, whether we are making plans with other people, going and meeting our friends, going and meeting our relatives, it involves several domains of our brain which require, let's say, attention, problem solving, interpersonal relations. So all of these things, hearing, visual. So a lot of the domains of our brain are engaged in social activities. So social isolation is a definite risk factor for longer-term cognitive impairment. Now, early warning signs of cognitive dysfunction. So some of us ask, how do we know that, how do we catch it early? Should we really wait until it's too late in the disease that, we pick up dementia when it's so far out that we can't even do any of the mitigation strategies that would maybe slow down the progression of cognitive impairment? So one of them is olfactory dysfunction. So some studies have actually shown that olfactory dysfunction is a pretty reliable clinical marker of early neurodegenerative process. It means our sense of smell gets affected early on. It means it occurs before the motor and the cognitive function symptoms, and it can occur in the early stages of most Parkinson's and Alzheimer's patients. So this can often present as a decline in the sense of taste, new or worsened sustained inability to smell. So the inability to smell has to be sustained. It can't be just an acute phase, come and go. Because if it recovers, then I think we should be okay. Requiring stronger flavors in food. Sometimes there's even a preference for sweet foods in patients who have dementia, which means that, one of the things we lose early in neurodegeneration can be our smell and taste receptors. The differential diagnosis, that means the other alternate reasons to consider this kind of smell dysfunction in the sense of smell, is chronic anosmia, means chronic inability to smell of other etiology, other cause, Post-COVID anosmia, which is a huge issue that we see these days after the pandemic. So before the pandemic, this wasn't so confusing, but after the pandemic, we're seeing a lot of people who have sustained inability to smell that may not be related to dementia per se. And then we have acute or post-acute viral anosmia, which means that sometimes in viral infections, upper respiratory infections, we temporarily lose our sense of smell. And that should not be confused with dementia or dementia-related sense of loss of sense of smell. The second early warning sign is having trouble coming up with the right words to describe something. For doctors, this correlates with confrontational naming, which means that when we present an object to a patient who we are, suspecting may not be able to find the right word to describe it, we present them with an object, something that's commonly used, and they're not able to say what that object is. They're not able to name it. Maybe they recognize it, but they're not able to bring the right word out. So that is something that also gets affected early on. Forgetting or missing events. Let's say that they have a family event or any festival or any get-together that they have to go to, sometimes even a dinner with friends. So they may forget those. Misplacing routinely used objects frequently. Difficulty with language or visual spatial. So, where we are not, especially in like memory testing or cognitive testing, we see that language and visual spatial domains are affected. And this is especially for any of the clinical folks who are listening in. That's something that we need to look out for. Now, history and unique clinical features. It's always important to exclude treatable causes first. I keep reiterating this because it is really important to recognize that there's something else that may be going on in this individual. Sometimes they're really living a normal life and then suddenly something happens. There's an inciting event that's usually missed. The loved one is not able to describe that this particular individual had a fall at home, maybe 6 months ago, maybe hurt their head. We don't really know. We're not able to get a full history. Sometimes they're living alone and we're not able to get that information accurately either. So we don't really quite know the full story, which is why we need to fill those gaps with our own understanding of what could be the alternate cause of this person's memory impairment. Is it dementia or could it be something else? So what is that something else? There's a whole list. Space-occupying lesions such as subdural hematomas, brain tumors, psychological disorders, depression with psychotic features can very much present just like dementia. So it's really important for us to exclude that. Polypharmacy or multiple medications can often mimic dementia because let's say somebody prescribes a medication for a particular symptom. That medication has a side effect. So another doctor prescribes another medication to treat that side effect, and so on and so forth. And you have something called as a prescription cascade. So polypharmacy means many medications which interact in a very complex mechanism with each other and with the patient's body, and of course with the patient's brain. And this can produce a cognitive decline over time, and it can be over weeks to months, very much mimicking the onset of dementia. Hearing impairment can often mimic dementia because we're trying to talk to our loved one at home and we think, oh, they're not listening to me, or they're asking the same questions over and over again because they didn't hear us respond to their question. So it's not that they've forgotten, it's just that they can't hear what we're saying. So it's important to rule out or exclude hearing impairment when it comes to anybody who seems to be having memory issues. Delirium is an acute confusional state which can mimic dementia, but it's usually because of an underlying cause, and it has a rather sudden or quick onset of symptoms. They're confused, it may be usually over days. Without any preceding issues with memory, it usually is an infection or low sodium or medication side effect. It's got a bunch of causes. So delirium needs to be ruled out. Infection is another one. Any kind of infection, chronic infection, the brain can do that, sometimes tuberculosis. There are many causes which can lead to a memory impairment. Hypothyroidism is one of the things we also think about. So we do a thyroid screening. Vitamin B12 deficiency is one of the other important causes that we need to rule out. Along with the vitamin B12 level, we also recommend something called as a methylmalonic acid level to exclude B12 deficiency with certainty. We also have to think about elder abuse because older adults who are abused often become reclusive. They become less interactive with other people. They tend to go off into their own shell. They may not want to speak about what's happening with them. So that's something we need to have in the back of our mind at all times. Alcohol-related cognitive impairment, obviously there's a history of alcoholism. It may be important to get that history from family members, from friends, or people who live next to the individual who's affected. Then we think about sleep apnea. Obstructive sleep apnea is a condition where we have periodic lack of oxygen to the lack of oxygen delivery to the brain when the individual is sleeping. And this can happen because of a mechanism in the throat that's dysfunctional, that's not allowing the airway to stay open when they are sleeping at night. So this can mimic symptoms of dementia long term. That needs to be ruled out because it's treatable. Heart or lung disease, chronic heart or lung disease, where we have a low output state. The blood and oxygen delivery mechanisms are compromised because of heart or lung disease and can lead to dementia-like symptoms over time. Next, why is it important to diagnose the type of dementia before starting medications? Now we say, okay, we have all these other causes, we exclude them, and then we say, okay, this looks like it may be dementia. But it's important to recognize the type of dementia that we're dealing with. It can't just be a bracket or blanket term, dementia. Because there is a type of dementia called as dementia with Lewy bodies, or DLB. These patients have a deficiency in dopaminergic neurons, or the neurons that produce dopamine in a certain part of the brain. And that can adversely, the patients can adversely react quite severely to antipsychotics. So very commonly, these patients come in with a hallucination, visual hallucinations. They're seeing crawling insects, animals in the room, which don't exist. And, they come in quite distressed. The relative comes in saying there's something going on. My husband's been seeing things. I'm not really sure what's going on. So our reflex is to just go ahead and say, okay, maybe I can try a small dose of antipsychotic. Not recommended until we rule out dementia with Lewy bodies, because these patients do very poorly. They, in fact, react very adversely to antipsychotics. Clinically, it's important to differentiate, let's say, frontotemporal dementia, which is a separate FTD, which is a separate type of dementia from Alzheimer's patients. Because frontotemporal dementia patients can have adverse effects to the medications that are used to treat Alzheimer's disease, such as donepezil, galantamine, or rivastigmine. So the medication that is used to treat each type, or the strategy used to treat each type of dementia, the prognosis, the symptoms, everything is very diverse. That's the reason it's important to recognize what type of dementia we're dealing with. Next slide. Let's go to history and unique clinical features. So this is mainly for clinical folks listening in. For Alzheimer's disease, the family history is usually a clue. Usually, this is a later life onset, slower decline, but you can have early onset Alzheimer's in 60s, which can progress a little more rapidly than the later onset ones. They usually have language and visual spatial deficits on your memory screening on MoCA or MMSE. Amnestic MCI, or amnestic mild cognitive impairment, may be a precursor. So if we do have any old notes, neurologist has seen them before, geriatrician has seen them before, neuropsychologist has seen them before, you may have access to those notes saying that this person has an amnestic type of MCI, and that may be a clue that this patient is actually progressing to Alzheimer's. Dementia with Lewy bodies, this is a very distinct type of dementia. The characters of fluctuating cognition, they have periods of extreme alertness, and then they have periods where they're very confused in the same day. They have REM, sleep behavioral disorder, detailed visual hallucinations, they're able to describe what they saw. Whether it's a small animals are usually what they see as a part of their hallucinations, or it's an insect, they see something like a cat or a mouse or a dog. So they have very detailed visual hallucinations. It's not just something in the side of the room. They know what they're seeing. And then you have Parkinson's features, which appear late in the course of the disease. So it's not the other way around. You don't see Parkinson's features first, followed by all of these. You see the Parkinson's features closer to the later stages of the disease. Now, the other suggestive symptoms are they have a severe antipsychotic sensitivity. As I mentioned before, they are very sensitive. They react very poorly to antipsychotic treatment. Their symptoms worsen, in fact. They have recurrent falls. They may have autonomic dysfunction in the form of constipation, lack of urinary control or urinary incontinence, repeated syncope, where they keep losing consciousness for limited periods of time and then they recover. Orthostatic hypotension, which means that when they stand up from a sitting position or they sit up from a lying down position, their blood pressure drops significantly, sometimes even leading to symptoms of lightheadedness. Depression, anxiety, systematized delusions. They have delusions of being persecuted. Somebody's out to get me. They don't like me. They're plotting against me. So very systematized delusions. The important question to ask the caregiver is daytime drowsiness, lethargy, staring into space, episodes of disorganized speech. If any of these are present, points more towards Lewy body dementia. The third one we're discussing today is vascular dementia. It's important to get the history here because there is a stepwise decline. Each time a stroke or a mini stroke occurs, they have a decline in their cognition. And then they remain stable. And then again, they have a decline in their cognition when another acute cerebrovascular accident or CVA occurs. Visual spatial fields may be affected on our memory screening. MRI CT features of old stroke or significant white matter changes. Either of these or both of these can be present on imaging, on simple brain imaging. Corresponding deficits in function will be there. If a particular area of the brain is affected, you'll also see deficits in function along with the onset of dementia. So history is very important in vascular dementia. Frontotemporal dementia has an earlier onset. Usually it happens in the 60s. The patients have very characteristic clinical features. They have disinhibition, which means that they're not inhibited in what they say. They speak anything. The kind of things that your and my brain might be, very careful about saying, even if we think it, their brain won't have that barrier. Every single thought that's going on just comes out. Then you have inappropriate words and behavior. You have apathy, where they don't really care about happiness, sadness, good, bad. They're just indifferent. Then you have lack of empathy. That's a very, very classic sign. And they have compulsive behaviors. For example, they may keep going and turning on and off a switch, or they may keep performing a particular activity repeatedly without a break. So that's a compulsive behavior. Alcohol-related dementia, the last one, is there is an alcoholism history. The patient usually confabulates or makes up stories to fill gaps in memory. And they may have a cerebellar dysfunction because long-term alcoholism affects the cerebellum and the way our muscles coordinate. So we're going to have coordination issues. Next slide. So you might have heard about MOCA and MMSE, the most basic screening tools that are used in almost any geriatrician or neurologist or even physicians who screen for neurological or neuropsych or dementia-related disorders. So MOCA has more sensitivity. It's a Montreal Cognitive Assessment. It has more sensitivity and diagnostic accuracy, and it has a visual spatial assessment. MMSE, or the mini mental scale, is it has lower education levels. I mean, it's good for lower education levels as opposed to MOCA, which requires a certain amount of minimal education. Using diagnostic tools, how do we get a cohesive diagnosis, let's say for example, in dementia of Lewy bodies? In the MOCA, you see attention, executive, and visual spatial deficits. In a SPECT or PET scan, you see reduced dopamine transporter uptake in basal ganglia on SPECT, and you see reduced occipital activity and cingulate island sign on FDG PET. And in polysomnography or a sleep study, you see REM sleep without atonia, which means that during REM sleep, healthy individuals with a healthy brain will lose muscle tone. So as they're having thoughts and dreams going on during REM sleep, their muscles are in a state of no movement. They can't actually move because even if you're running in your dream, you're not actually running in real life. Now, a person with REM behavioral disorders, such as a person with dementia of Lewy bodies, will lose they'll have REM sleep without atonia, which means that they will have muscle tone. They will be moving. They'll probably be kicking the person who's sleeping next to them. So that's something to keep in mind about DLB or dementia of Lewy bodies. Next slide. Using diagnostic tools for a cohesive diagnosis in, let's say, Alzheimer's dementia. What does a MoCA show? MoCA shows that in AD, we have attention, executive, visual, spatial issues, or that particular domain is affected in the MoCA. FDG PET. So when you look at these two, dementia Lewy bodies and Alzheimer's dementia, you see that there's a lot of overlap in the domains on screening. So the deficits in particular domains, they overlap a lot. So you can understand why the screening tool is not good to differentiate between the types of dementia. The screening tool is good to establish that there is some cognitive deficit and it's more in this, and this domain. But it's very hard to tell with just the screening tool alone what kind of dementia this is. The history is needed, and sometimes we need supportive diagnostic tools, as we're going to speak about. FDG PET, same slide. FDG PET in patients with mild cognitive impairment, which is often a precursor or the previous step to Alzheimer's. The FDG PET is better than all other imaging modalities in diagnosing and predicting conversion of mild cognitive impairment to Alzheimer's dementia. So consider that about roughly 50% of mild cognitive impairment patients may progress to Alzheimer's dementia, while 50% don't progress in that lifetime. Areas of decreased glucose metabolism. So the FDG PET is a particular type of test that assesses the glucose metabolism or the glucose uptake. It is attached to a particular molecule, which is the FDG molecule, and that image is looked at through a scanner. So decreased glucose metabolism or uptake of glucose is reduced in the posterior cingulate cortex, the precuneus, inferior parietal lobe, medial temporal gyrus. Areas of decreased glucose metabolism in the posterior cingulate cortex is wider in Alzheimer's dementia when compared with mild cognitive impairment. So this is a differentiating feature that's important for us to know as clinicians. And it also extends to what we call as the precuneus area. Decreased glucose metabolism in the lateral parietal cortex is usually only found in AD, as per this study that was published, as per this particular imaging study that was published by Charles Marcus. So we'll go through a few images. This purple, so what we see here is the gray area, all of the gray is the brain. The purple areas, and these are the ones that have lower glucose uptake. In other words, they are the areas that are affected in this particular type of dementia. So if we talk about dementia of Lewy bodies, you see that glucose has a reduced uptake or glucose hypometabolism in bilateral occipital lobes, which means the lobes that's on the backside. The parietal cortex, which is more towards the center, and then extending to the temporal cortex. So if you look at it, it involves that particular area. So a FDG PET is one of the most useful tests when it comes to helping us understand, especially in early dementia where the different features cannot be very easily distinguished. History may be, missing. We may not have an entire picture of everything. That time, an FDG PET could be very useful in helping us understand where the pathology may be originating from. Now, what does the FDG PET in Alzheimer's dementia looks like? Now, this picture of the brain looks very different because different areas of the brain are being affected. Glucose hypometabolism or low uptake is seen in or rather low utilization of glucose rather than low uptake, would be temporoparietal, inferior parietal, medial temporal, as well as the posterior cingulate cortices. So it's more generalized. Large areas of the brain are affected in this. In patients with mild cognitive impairment who developed Alzheimer's dementia within a year, in comparison with normal subjects and patients with stable mild cognitive impairment. So these particular 4 areas are very telling that this patient with MCI, let's say, will likely progress to Alzheimer's dementia. And what this particular study showed by Charles Marcus, the one that was published, it said that if you had a patient with MCI who did not progress, these areas were less likely to be involved in that time. Now, the next one is frontotemporal dementia, or FTD. Different type of dementia, like we said, it's more of, they don't have judgment, they have disinhibition, inappropriate behavior and words, lack of empathy, apathy. So all of these things are very classic in frontotemporal dementia. If you look at where the brain is affected, the purple areas are now more on the front side of the brain, and they involve some part of the temporal lobes as well. So you see that the glucose hypometabolism is in bilateral, frontal, and temporal cortices, which mean both the sides, but more in the front and the temporal lobes. Next slide. So we can use more detailed diagnostic tools. So one of the thing is when we use the brain function and memory scale and the EEG. We do see that there are some indices that are very useful in understanding who we need to screen for certain pathologies. For example, in one particular study that was done by Liu et al., there was a cohort of patients who had a particular higher index in the implicit cognitive threshold as well as cognitive efficiency. So in these patients, it is important to recognize that when we look at their EEG, it correlates with high amplitude fast waves. What is important about that is we have to look at screening or ruling out Parkinson's and dementia risk in these particular individuals who may have early cognitive impairment. So overall, what I intend to share with this slide is that even EEG can be a very useful tool early on in dementia and neurocognitive disorders to understand where the pathology might be. In dementia of Lewy bodies, we see prominent posterior slow wave activity with periodic fluctuation in the pre-alpha or the theta range. So this is particularly useful again if the patient cannot undergo any other form of testing or may not be able to afford. So we can look at EEG as an alternate mechanism also to help us support a diagnosis. Next. So now we move on to the real deal, which is how do we set the right expectations with caregivers? The important aspects in understanding dementia come from if we understand the different types of dementia ourselves as clinicians, and we also have some understanding as non-clinicians, it would help us set the expectation with caregivers as to what they can expect, because we have a full understanding of what the disease is about to look like over the next few months or years. So the first thing is to make an accurate diagnosis. All of the tools that I've shared in today's slides, as much as I could in the most concise way possible, was to ensure and reinforce that we make a correct diagnosis. And if that means we take a little extra time to make the diagnosis, that's fine. So dementia versus psych etiology, is there a psychological cause or psychiatric cause underneath? Or is there an alternate etiology? And the most important is if this is dementia, we have to know the type of dementia. Second point is we separately interview the patient's friends and family to get collateral information, because the patient may not be able to give all the information we need. And often the most useful information when it comes to delineating the cause of cognitive impairment comes from the patient's caregiver. Ensuring initial detailed clinical evaluation by a psychiatrist or neuropsych and a geriatrician or neurologist, along with MOCA, MMSE screening, followed by detailed neuropsychological testing and MRI, CT scan of the brain if needed, FDG PET or SPECT. Then you have a polysomnography or an electroencephalogram or EEG. All of these are good supporting measures to help us understand what the type of dementia could be. Then we use a consensus diagnosis, which would be very useful in this situation, because if we have more people who agree with the thought process that there is enough evidence to support that it is this particular process and not the alternate causes, then we can all proceed with more confidence that we are treating it the right way. Resist the urge to start antipsychotics, especially if there is any doubt that this could be dementia of Lewy bodies. Reassure the caregiver that correct diagnosis is more important, or rather the most important thing in this situation. Have a close follow-up plan. Even if the patient improves with treatment, it's okay. Call them in, assess for side effects, ensure compliance, reassess to ensure that you can count on them to be compliant with the medications that you've started on them on for symptoms, even just symptoms. Weekly follow-up is recommended initially until symptoms stabilize on the particular treatment regimen that we've started on for the patient. If lack of diagnostic clarity is present, clarify this with the caregiver with the plan in place for the next steps. It's okay to say, I don't know what this is right now, because the information we have is not enough to support a diagnosis one way or another. We will need to do more tests, or I'm going to refer you to another doctor who's going to conduct more detailed testing. For example, a neuropsychologist who's going to do a detailed 2 or 3 hour neuropsychological testing to help us get more information as to where the deficits are. So imaging can also be a part of it. We can also sometimes trial a medication and say, let's try this particular medication. I think it's, this is what the symptoms point towards. If we are not able to do any further testing, we can try this particular medication. If it works, then I think we're on the right path. But trial of medication without adequate information or a formal diagnosis is not recommended, because we do know that trying medications, if there is an alternate possibility of dementia, Lewy bodies, or frontotemporal dementia, giving them alternate medications can actually be harmful. So it's not recommended unless we are really confident that this could be the case. For young doctors, solving the puzzle early to avoid it getting more complicated is the key, because if we put it off for later, the puzzle just gets more and more complex. Creating a dementia chart or note for the patient with a full timeline of events and interventions up to date is very useful, because if somebody else has to care for the person in the emergency department, they know what to refer to, and they know what has been done, and they know what to do next. Next. We can skip this slide. Educating the caregiver fatigue. Most important thing is we look at something called its caregiver support for mitigating caregiver fatigue. So CGS is caregiver support and CGF is caregiver fatigue. Acceptance is key. Speaking with caregivers separately if we can is the key, because we need to ensure that we help them understand what they are dealing with. Cognitive impairment requires us to slow down, not to speed the patient up. Explaining to the caregiver that reinforcing cognitive deficits to patients only increases the patient's anxiety. So let's say we are dealing with a loved one, a grandparent or a parent in the family who's going through, cognitive deficits. They're increasingly forgetful. They ask questions again and again. So reinforcing that they're forgetting, that they're wrong, is only going to increase their anxiety. So helping the caregiver differentiate between their own expectation and the patient's expectation is important, because sometimes it gets muddled up. We assume that the patient is expecting the same things as us when we are a caregiver, but that's not entirely true. We may have more expectations out of them than they may be able to fulfill as our loved one. Clarify any mismatch between the caregiver's expectations and reality. Set the appropriate expectation of slowing down, because dementia requires us to slow down. Empathize, understand, and openly acknowledge. It is natural for the caregiver to experience uncertainty and worry about their loved one. It's a part of the acceptance process. So it's important for us as clinicians to hold space for that acceptance to develop. After a set period of validating the challenges, it's important to become solution-oriented, because this is not just about venting. This is also about solving this problem or the issues and challenges that arise as much as we can. Caregiver fatigue is associated with patient neglect, higher rates of depression, and heart attacks amongst caregivers. So this is really important to remember, because neglecting caregiver fatigue, or rather not supporting the caregivers enough, can often result in their fatigue, which results in harm to both the patient and the caregiver. So it's losing both people. Explore solutions. So hired caretaker would be of utmost importance to avoid caregiver fatigue. Do not assume affordability barriers up front. People may be able to get the kind of help they need regardless. So it's important to tell them that having a hired caregiver or caretaker is going to make all the difference in the world. Enable caregiver to support the patient well. Arrange for frequent OPD follow-ups, especially when caregiver fatigue is present, it's important. Endless support strategies such as community daycares, hired caretakers, caregiver support groups, connect with medical social worker. The second part of the slide is be curious about the caregiver because they're human. They have their own challenges and responsibilities. So it's important to know their life as well. If they're facing any challenges, then make sure that they're connected with the medical social worker so they can seek the appropriate medical psychological help for their own issues as well. Clearly outline the required support that the patient needs with their activities of daily living, as well as the instrumental activities of daily living. If they need help with finances or managing their telephone book or keeping their house clean or cooking, we need to ensure that this is very clearly stated and what they need help in. If they need help with bathing, if they need help with toileting, with eating, we need to make this very well known to the caregiver so they know what to do, what needs to be done for the patient, based on the areas of deficit that we are able to recognize during the visits. If the diagnosis of dementia has been made beyond doubt, clearly state to the caregiver that it is unlikely to be reversible or progressive if that is the case. Because it's important to set that expectation from the get-go as opposed to giving a hope that may not actually materialize. For hired caretaker, it's important to obtain the history from and educate directly, to ask them about all of the details of the history directly, not to outsource this to any of the family members or anybody else or a relative. It's important to have the hired caretaker in the clinic at each visit so we can get the history from them and we can educate them on what needs to be done next. Caregivers, it's important to avoid the temptation to play doctor at home or with Google. This requires us as doctors also to be present for the patient and the caregiver when they need us in the outpatient setting. Now, preparing the caregiver for handling their loved one with cognitive impairment. This is the last part of the presentation, but this is one of the most important aspects that we often miss. We have to be quality of life focused. We need to ensure that the caregiver understands the importance of the predictable and safe environment, familiar faces, and emotional support towards the patient. Because that familiarity is the only thing that's going to give any certainty to this individual who now has cognitive impairment. Actively reduce medication burden or polypharmacy and stress on preventing hospital admissions, because patients with dementia do much more poorly in hospitals or inpatient settings than do patients without dementia. Proactivity and prevention are the cornerstones of improving outcomes in individuals with cognitive impairment. Educating the caregiver about early warning signs of infections and to contact the geriatrician or the internist on outpatient basis early on for management rather than wait until an overt infection develops. Because we run to the emergency room when the fever is 104, but when the fever is 100 or 101, we just give a dolo and we sit on it. So it's important to educate caregivers and prepare them for this and say, if there is an infection, this is how its early infection signs can be. It may not even have a fever. Your loved one may just be confused, more confused than they usually are. So ensure that you talk to the doctor as soon as you see a change from their baseline or what you normally see them as, even while they have cognitive dysfunction. Fall prevention strategies. So patients with dementia, again, there's a correlation with falls. So it's important to ensure that we do everything to prevent falls in the home as well as in the community setting for these patients. So they're already frail, they're already fragile. It's important to not subject them to an increased risk of hip fractures or subdural hematomas, or for that matter, spine injuries. Equipping the caregiver with as needed or SOS medications for symptom management. So this is important because many of the times caregivers reach out to the provider asking for as needed medications. There may be a slight disturbance from baseline, maybe a little bit more agitation, maybe a little bit more sleeplessness, something that could easily be managed with a small dose or an extra dose of a medication. So that's something that we need to keep in mind. proactively ask for, any symptoms that are there and address them. That if this individual, if your loved one does develop this particular symptom, this would be try a half a tablet or a small dose of this particular medication. Discuss advance directive. So this is really important. An advance directive will basically tell us what the patient would want in case they were in, let's say hospitalized or in an unconscious state, what they would want in that situation, how aggressively they would like to be treated. Would they like to be placed on machines, invasive mechanical ventilation for that matter? Would they like those things? So it's important to have that in place, even if the patient is so cognitively impaired that they cannot vocalize those or actually speak those out. The next of kin who represents the patient best has to be able to vocalize this, because patients with dementia can deteriorate much quicker as well in the inpatient settings. So it's important to have the plan in place as to what they might and might not prefer in terms of aggressive treatment. Have an early goals of care discussion with the patient and the family, with the family most importantly, but with the patient also if possible. After establishing rapport, especially if the patient's dementia is rapidly progressive, if the patient has multiple comorbidities or diseases, if they have frequent falls, or they're much older, if they have advanced age. So these become important indicators that we have an early discussion on goals of care. What would you like? So it's very similar. It's a continuation of the advanced directive. What would you like if a situation were to arise where you are admitted to a hospital or an ICU and you're not able to make decisions? Explore the importance of medical and financial guardianship if the patient has dementia. With that, I conclude my slides. Thank you for listening in, and I'm happy to take any questions that you might have today.
Thank you, doctor. Thank you. It was a wonderful presentation.
Thank you.
Thank you. People have raised one or two questions. No, but before that, I just wanted to add only one point, doctor. Please tell me that. Only today, this advanced directive, only today, Government of India has published some directives on that. They have published what are all the things that needs to be considered for taking this advanced directive, and when in common parlance it is known as when the plug can be plucked. When the plug can be plucked. So that they have given some food for thought on that, and they have put it as a for public view. So this is one thing that has happened, doctor. See, I just thought of raising the questions. On one question has been raised by, one second, by Bache Gowda. See, he is asking any useful gadget tool which can be fixed for such dementia people individually.
Yes. So there are a bunch of tools. I can't say I know all of them, but I do know some of them because I've worked very closely with patients who used to use these. So one of them is something called as a life alert. You have, they're called as Medi Alert, Life Alert. It depends on the brand and the country and the region you're working in. In India, you see a lot of them have those little pendants. It's a pendant which they can press in case they have a fall and they are, they're in a, let's say, like, in an enclosed place, a bathroom, or they're outside, they're wandering, they're lost. So you have, there is something called as a life alert button. But it's important to remember that patient has to have enough memory and awareness that they're wearing a life alert button. A lot of dementia patients with advanced dementia may not even realize that they have that. And in fact, they get so annoyed with it that they try to remove it. They try to throw it out. So there are challenges that come with gadgets too, but in early stages where, the patient themselves is participating in their care, they have some awareness. Let's say you're dealing with an MCI patient, a mild cognitive impairment patient. You can offer them a life alert bracelet, especially if they're having frequent falls, or they tend to have a fall in the bathroom, or they're living alone without any support. It's important. Now that usually connects to a phone number, or they dials an emergency phone number to let somebody know that, let's say a kin, or, in the US, it used to be 911. But it can actually alert people that you've had a fall or you are in some kind of physical danger. So that's important to remember. What we also have to keep in mind is this can be misused. So sometimes they may, let's say you have an advanced dementia patient, they may just keep pressing on it because it's a button and they have no awareness or memory of what it was there for. There are a bunch of good gadgets that are used to improve, like the functioning for Parkinson's patient. Again, Parkinson's is not necessarily dementia, but Parkinson's patients do develop dementia in the later stages. So there are some gadgets to help them as well to reduce the risk of falls. There's some very ingenious gadgets that have come in the last, I believe, 4 to 5 years. It's quite good. I think there's also something called you have the medical bracelet. So let's say you have a dementia, a loved one with dementia at home, and you're worried about them wandering and going off of their own. Let's say into the community, they're just walking, they have a tendency to get lost. So you have their full name, address, and emergency contact number on a metal bracelet, which is hard to remove. So anybody who sees them and who has an inkling that this person may have memory issues and is lost can find the requisite information and contact the right people. Of course, it depends on a lot of things like Good Samaritans and ensuring that people actually care enough to do these things. So some of it is social participation, but a large part of it is there are gadgets available to help these individuals. Are there gadgets that can reverse the process of dementia or really help the pathology? I think a lot of it is more under experimentation. I don't think so far there's been any gadgets that's shown to reduce or let's say reverse the progression of dementia per se. But there are gadgets to support individuals who have dementia.
No, but doctor, you are mentioning one thing that in a dementia care setup, the patients are not doing that good compared to the people who are retained at their homes. Is it a fact, doctor?
So I don't think that is true entirely because that's a very large generalization. There are people who do well in dementia care centers that are managed well, that are staffed with adequate nursing, who are educated well enough to take care, because a lot of dementia care is actually nursing care. And it's more of companion care, right? And then you have healthcare providers, doctors who are invested in the well-being of the patient and don't actually end up over-medicating the patient for symptom control. So a large part of it is not just having the space, but also the right intention, the right practices. So a whole environment has to come together cohesively to provide care for the dementia patient. Ideal dementia communities are large, have open spaces, do not confine patients a lot, have adequate staffing to actually be with the patient, to accompany the patient at different times so that even if they're wandering, they are safe. Even if they go off away from their rooms, they are supervised. So that reduces our dependency on over-medicating patients to keep them safe. So dementia facilities, it really depends on the facility. It's not true that patients can do better at home. It all depends on the type of support. Having said that, conversely, you have situations where patients are living at home and they have no support. There is nobody to take care of them. There's no hired caretaker. There's no family member. So they end up being a product of neglect. So that it can backfire. So intention and what we have on the ground, what we put on the ground becomes really important in dementia care. It can happen in any environment so far as we do it right.
Yeah, that helps me, doctor. In fact, one more thing I just wanted to ask you is that, can I share your contact details, because you are presenting so nice. So many people are asking when can we meet the doctor?
Sure, absolutely. Would an email address suffice, or would you be able to send out the contact number to them after our meeting is over? Is that okay?
I would rather suggest you to send an email address so that I can share that email address to people, so that whoever would like to see you, they can definitely see you. That is, people have been, impressed by so much that
it is not correct to publish openly.
No, that is right. She will give it to me.
Every time we should not ask personal numbers from your doctor.
That is what I said, sir. Sir, kindly remember, I said your email address will be better.
So I think Mr. Jambu, I think Jyoti will be sharing the email address with you. So anybody who wants to get in touch with me, feel free. Mr. Jambu will be sharing the email address personally with you.
Yeah. What I said, but I normally do not share any phone numbers because it's disturbing. People may not realize your busyness, etc., etc. Therefore, normally I do not.
Oh, absolutely. I'm reachable via email. Just ensure that you introduce yourself. Please take the email address from Mr. Jambu. Give your contact details and ensure that he is in touch with you. And you can absolutely get in touch with me for your needs. Not an issue. I'm happy to help in any way I can.
That's very nice of you.
Yeah. Jamunathan sir, I have one small question.
Please.
For physically handicapped and this dementia people, I was told that Google is developing a tool which could be of use in days to come. I don't know what is the stage of that. Secondly, because there are many missing issues are there. Every WhatsApp we can see somebody is in bus stand, somebody is in railway station, identify him and the photo, they are putting up photos. So for such people and for future, at least if not as of now, for such people, if it is fixed, because we have seen even our retired officer also came midnight and see that the vehicle has gone, that gone, that route has gone, or he was a milk distribution officer. Like that, suddenly he has come out from the house at midnight after 2 a.m. So then he was searching in the security that vehicles have gone or not. He's verifying, in fact. So like that, when at least when they came out, if it is some gadget is fixed, people can trace and take back. Not only a diary, once he went to Bangalore without notice of their family. So like that, if that tools, of course, then earlier days there was no tools of this type, and education was not that like that what Vayomanasa and Jamunathan is presenting or coordinating. So earlier days we were so situation was not at all good. At least now WhatsApp, so many advertisements, so many TVs, people can missing people can be notified. So that tools, they definitely Google, you have to have pressure on them and get some tools, affordable tools for physical handicap and this dementia people or any senior citizens of age above 80 or something.
Speaking. I'm so sorry. Who was it? Mr. Gowda who had?
Yes, doctor.
Okay. I completely understand and I resonate with your thoughts. I agree that I think tech is one of the most important strengths we have today. I know a lot of people are saying, oh, is AI going to, make things worse? Is it going to make things better? So AI is just definitely one part of it. But, tech in general, wearable technology in general is going to be a game changer, is already a game changer in the care of elderly patients, but it's going to continue to be one. Should we pressurize these folks? No, a lot of the things they're doing is for profit. They don't need any more pressure. They already have all the pressure, all the incentive to do it. So don't worry about that. None of the pressure we're going to put is also going to speed up any of the process. What we can do, where geriatricians really come into play, is we tag team with many of these folks and really tell them where it's useful to, what would be useful, or how we can come up with something different or ingenious. So we can collaborate and work with them, provided that's something they are interested in. But having said that, there is no doubt about the fact that wearable technology and technology is going to change the way care is provided. In fact, already in hospitals, we have a lot of remote care monitoring. So I don't know if any of you have realized this while maybe, your loved one has stayed in a hospital, there's a heart monitor that they connect your loved one to. And then, the nurses at the station, doctors at the station outside can actually see and know what's going on with your loved one. They know their heart rate, they know their blood pressure, they know their breathing rate, their oxygen levels, everything. So
like
it's called
CGM also, like CGM, glucose monitoring device.
Similar, right.
Yeah.
So you have something called as a cardiac telemetry. So that's one of the early technology tools that's considered, in some part wearable as an inpatient. So you attach the electrodes to the patient and you know what's going on remotely. You have a lot more advanced devices which can do a lot more these days. Of course, it comes at a price. but that doesn't mean it does not exist. So we do have a lot of advancements, and with time, these are going to become more affordable and more practical. So definitely we're going to have things to reduce falls, alert people about falls, safety. All of these things will come into place with time. I would say anywhere between the next 2 to 3 years, we're going to see a huge boom in this.
If that is going to be so early,
Yeah.
we should really thank our stars. Because, I mean, normally these technological improvements, they take lots of time to come into market.
We already have a lot. A lot of prototypes are already done. They've already been tested. It's all about getting it out in the market. So you
No,
will
it
see
should
a lot
not
of
be in
things
the
come out
lab
in-
only. It should reach land, lab to land. It should reach the lower section of the people at a affordable price.
That is again, see, in fact, we are now talking about affordability at all levels.
Yeah.
Not affordability at higher levels. There are people, I mean, now this dementia is more prevalent in people with lesser income. That's a real challenge.
So I think there was a very interesting comment. If you don't mind scrolling up a little bit, Jyoti, there was a very interesting comment. A little bit more. Scroll up. Can a good lifestyle? So Nagaraj Rao has asked, can a good lifestyle avoid getting into these problems? So one of the things I focus on a lot is preventive care. When I look at patients with dementia, when I look at patients with neurological disorders, it pushed me towards thinking, what is causing these things? How can we prevent these things in younger individuals? How do I prevent these things in 30-year-olds, 40-year-olds, and 50-year-olds? Can I help screen them better? Can I ensure that they get more holistic screening, better advice in terms of lifestyle? Absolutely. So let's talk about dementia patients. Dementia patients themselves can actually socialize more and get more physical activities. These are the two proven measures to slow down the progression of dementia. So social activity as well as physical activity becomes really important in patients with existing dementia. Now, if you want to mitigate those things and we want to keep an active and healthy brain as we grow older, it's important to have the right kind of diet. And that would mean a good whole food, plant-based diet. This is one of the diets that's been associated with healthy longevity. If you do have time, read up about the blue zones, 7 magical zones across the world where people live very well, cognitively sharp to a very long age, sometimes even way past their hundreds, well into their 90s at the very least. So you can read about the blue zones. It's very interesting. They do follow largely a whole food plant-based diet. They have a lot of social activity. They have a lot of physical activity, basic bare minimum physical activity and outdoor time. So important to recognize that lifestyle is actually very important. If you were to take away lifestyle measures that can help you keep these away as much as possible, it would be daily physical activity. Walk for 45 minutes to 1 hour daily at bare minimum. If you can do more than that, if you can do weight training, if you can do strength training, resistance training, swimming, sports, fantastic. Just make sure that you're in the right kind of cardiovascular or heart health in order to tolerate that level of exercise. So that's important. Second one, follow a good diet, no fried foods, no processed foods, no biscuits, cookies, cakes, none of that. Follow lots of fruits, vegetables, rice, grains, whole food, rice, dal, grains in your diet, and you should be good. Ensuring that we don't keep ourselves lonely is the third thing. Enjoy a lot of good socializing. So these are good lifestyle measures that we need to continue in order to keep our brain healthy.
That's great. That's great. I mean, beautiful. Yes. Any other question from any person? Because doctor's time is also important. We are already running very much. Yes.
Big noise in the air.
Only one thing. Somebody has asked whether we will get a recording of this. So please be assured that it will be available in a couple of days in our VMS YouTube channel. It's completely recorded, and our team, backend team, volunteers from NIMHANS will post this in the VMS YouTube channel in due course, maybe in another 2 days' time. Am I right, Jyoti?
Yes, sir. Today I will be uploading it to the YouTube. By tomorrow, they will be getting the video in the YouTube channel. Share the link in the group also.
Yeah, it will be there in the group also.
Yeah.
We'll try to push it.
Yes, it will be available.
that this information is availability in eternity, and doctor is also availability in eternity.
That is the hope.
So we can conclude the session now. Sir, you can conclude it. Yeah.
So, see, in fact, one thing I wanted to again thank Dr. Aarthi is that, see, she is a very busy doctor. In her busyness, she has found the time and come to us and talk about in an extensive way all things about this dementia and how to take care of people is something excellent. I mean, from the bottom of our heart, we thank you for that. And in all this, for all these things, what we can wish is that we can pray God to shower on you and your family all that are the best in your life. That is the only wish that we can do, Mom. That is the only prayer that we can do. And
Yes.
Wanted to add for this VMS people is that, see, tomorrow is International Senior Citizens Day or Elders Day. So on the year of that International Senior Citizens Day, this beautiful program has come in. So thank you very much. It's a very good gift for all of us. Thank you. God bless you.
Happy International Senior Citizens Day to everyone. Thank you for your time. I hope all of you continue to do well and keep well.
Most of us are that way blessed. We are all very well. The only thing is we want the entire society to be well. That is why we are all coming here. Thank you. Thank you for your time once again.
Thank you.
Thank you, Jyoti. And
Thanks, doctor. Thanks very much.
Thank you, sir. Yeah. Thank you, ma'am.
Thank you very much.
Jyoti, you can close down.